Good morning. My name is Katarina Sjögreen Gleisner. I'm at Medical Radiation Physics at Lund University in Sweden. And I will give you some perspectives on the integration of dosimetry in molecular radiotherapy. These are my disclosures. Molecular radiotherapy refers to the use of unsealed radioactive drugs or substances for therapy of benign and malignant medical conditions. And indeed, molecular radiotherapy or MRT arose by many names. It is also being referred to as radiopharmaceutical therapy, radionuclide therapy, targeted radionuclide therapy, and so forth. And in part, these different names has to do with the vector that is used to carry the radioactive nuclei to the disease region, and in part it has to do with the kind of radionuclides being used. Radionuclides used are those that emit particles at their radioactive decay. And most commonly, it is still beta-emitting radionuclides, and these listed are those that are part of approved compounds for MRT. Also upcoming is alpha emitter-based radiopharmaceuticals, where there is currently one approved, which is 2-3 radium. The physical half-life is typically in the order of days of these decays. There are a number of medical conditions that are being treated with MRT. The most common still being those emanating from thyroid, so it's benign thyroid conditions and thyroid cancer. Quite common is also neuroendocrine disease, where it's most commonly the radionuclide lutetium. Quite recently, treatment of disseminated prostate cancer using lutetium PSMA was approved in the EU. And intraarterial treatments in the liver using yttrium or holmium-166 microspheres is also quite common today. This is a brief timeline of the introduction of various radiopharmaceuticals. And it actually began already during the 1930s or 40s, especially with iodine-131 and iodide. Then there was a few radiopharmaceuticals introduced during the 1980s and until 2000. But there was also an intensive research going on. Now, during the last 20 years, there has been more intensive research, and there are several radiopharmaceuticals and radioactive compounds that have been introduced. And given by the current investments in pharma industry, more are to come. Currently, the recommended posologies or the dosing of these radiopharmaceuticals is mostly given in fixed activity levels. So these are just some examples. They are stated in millicurie, which is also to show the reason for these levels, which is in even numbers of hundreds. And you can see at the bottom how to convert it to megabecquerel. The vast majority of these treatments are given with fixed activity administrations. And this is where the debate comes into play, which is whether absorbed doses to organs, tissues, and tumors matter for the risk of toxicity and probability of the effectiveness of treatment in molecular radiotherapy. And then, should dosimetry be performed for the individual patient? And this is where the status of the field is right now. There is a debate going on, and there are many different opinions. And I must confess that I am opinionated here. I am in favor of doing dosimetry for molecular radiotherapy. this was also, position was taken in this position statement by the IFOMP, which was issued in 23. And this is a position statement that also includes a number of recommendations in order to enable the transition from administration of fixed activity to personalized treatment based on patient-specific dosimetry in molecular radiotherapy. The underlying reasons for this debate, I think, are best seen if we take a step back and look at molecular radiotherapy from the perspective of ionizing radiation science. So as we know, there are several operations in society and industry that involve the use of ionizing radiation. This is a map over the Fukushima Daiichi region, where there was a release in 2011 owing to that accident. And in this environmental situation, the absorbed doses are typically well below 100 milligray. So we use cohort average dosimetry to estimate the risks associated with radiation exposure. The same procedures are used in diagnostics. This is a PET CT scan. And again, absorbed doses are comparably low, and we use cohort average dosimetry. And we do that to calculate the effective dose, where we convert from absorbed doses via weighting factors for radiation quality, and then also risks of different tissues of developing cancer. So effective dose is only used to estimate risks in populations and not for individuals. And we use the unit millisievert for that. So if we then go on to therapy, it is instead the absorbed dose to organs, tissues, or tumors, which is the relevant quantities. And the reason for that is that the absorbed doses are so much higher. It's a considerable span of absorbed doses. If you look at the whole scale, it's several orders of magnitude. And the reason we are looking at absorbed doses to the individuals and to individual tissues is that we aim to achieve a balance between tumor control and toxicity for the individual patient. These radiotherapeutic principles, if you may say, are applied in external beam radiotherapy, where there is an ever ongoing development of increasing precision and dosimetry and in the delivery of radiation. And if we look at the delivery of radiation energy and absorbed doses using external beams, they are normally given by fairly parallel photon beams that give rise to an affluence of electrons, which is what delivers the absorbed dose. If we use sealed radioactive sources inside the body, as in brachytherapy, we have again most often a photon field which is more divergent than for external beam radiotherapy, but the mechanism of action is again photons that generate affluence of electrons that delivers the absorbed dose. We can also use unsealed radioactive sources inside the body, as in molecular radiotherapy. In this case, we instead have the radioactive decay, which gives affluence of beta electrons, which is what delivers the absorbed dose. Then that also often emits photons, which are useful for imaging and dosimetry. So given these apparent similarities, its deposition of radiation energy, then dosimetry would seem to be natural. and yes, it is for external beam radiotherapy and brachytherapy, however, not to a large extent for molecular radiotherapy. And this is where the debate comes into play. So what do regulations say? Well, this is the European directive, which was published in 2013. And this directive says that for all medical exposure of patients for radiotherapeutic purposes, exposures of target volumes shall be individually planned and their delivery appropriately verified, taking into account that doses to non-target volumes and tissues shall be as low as reasonably achievable and consistent with the intended radiotherapeutic purpose of the exposure. And in definition, it stated that radiotherapeutic means pertaining to radiotherapy, including nuclear medicine for therapeutic purposes. The European directive develops based on recommendations from several international radiation protection organizations. So there is a network of organizations. So, for example, there is the ICRU, the ICRP, and the IAEA, with abbreviations written on bottom, that all feed information and recommendations into the EU that then form their directives. These three organizations have quite recently issued report that are unanimous on the position of dosimetry and MRT, that it should be integrated in MRT for the benefit of patients. So what is the issue? Are there no methods around? Well, yes, this is a meta-analysis of the number of dosimetry publications between 1950 and 2022 of the use of dosimetry and dosimetry methods. And as we see, there is an increase over the years. Is there no evidence of relationships between absorbed dose and effects in patients? Well, yes, there is. This is a summary paper of the current evidence in 2014. So it's now 10 years old. But more recently, a lot of evidence has been gathered in different kinds of MRT. And if I should just give a taste of some more recent examples, this is from a study of lutetium PSMA for the treatment of disseminated prostate cancer, where they looked at patients who responded after 12 weeks versus those who did not respond, and studied the mean absorbed dose to the tumor and saw a significant difference between responders and non-responders. This is for treatment of disseminated neuroendocrine tumors using lutetium dotatate, where this year 2 groups presented relationships between the absorbed dose and the tumor control probability. And for patients with the neuroendocrine tumors, there is also evidence of the use of dosimetry to predict progression-free and overall survival. Another example is for radioembolization using yttrium-93 microspheres, where this study showed large difference depending on if they use personalized dosimetry or standard dosimetry for microsphere treatment. So this is just to try and summarize the debate and the arguments. Myself, I have an opinion, so I'm trying to be transparent about that. So from a regulatory viewpoint, individualized dosimetry in molecular radiotherapy is mandatory. From a scientific and radiotherapeutic viewpoint, dosimetry can provide essential information that in the long term we believe will enable personalized treatments. And if we look at the timeline, historically the risk of toxicity have been modest in MRT, But with the introduction of new compounds, this has changed. The risks of toxicity are now more evident. And in parallel, the capacity to perform 3D dosimetry based on SPECT-CT systems has increased considerably. So on the good side, we believe that nuclear medicine has a window of opportunity to offer better optimized MRT. On the other hand, there are yet many lacking pieces to incorporate dosimetry into clinical practice. There is a lack of infrastructure. There is a lack of methods and know-how. It is difficult to fit in repeated camera time in current nuclear medicine departments. And there is no system for reimbursement in most countries for dosimetry. There are also many medical arguments around. For example, that MRT is mostly used for treatment of metastatic disease for patients in poor conditions. And some think it's unnecessary to make procedures overly complicated. Also, there is a lack of randomized trials that compare standard fixed activity against dosimetry guided treatments. This is the way it is. So now the debate continues, and that's occurring on many different levels currently. But I can't help thinking, why be blind when we can see? I truly believe dosimetry has much to offer. And this is all from me. Thank you so much for your attention.